All right. Good evening. My name is Bob Akivi. I'll be hosting tonight's session of the Virtual Tumor Board. Greetings from all of you from New York. It's a overcast day in New York, but it's perfect weather nowadays. And the COVID hasn't come back with force too much. Tonight we have an excellent panel, and I see a lot of guest faculty as well. We will be discussing soft tissue reconstruction. We have Drs. Matthew Old, Douglas Chapaya, Rusha Patel, Michael Moore, Arno Bewley. I see Dr. Reed, and I see Steve Kang as our faculty. And so let's get started. As you know, it's 20 minutes, so we try to finish everything in 20 minutes. So I think our first presenter is Dr. Fowler, correct? From Case Western Reserve. Let's just start.
Okay, so so excited to be able to talk to you guys through our laryngeal pharyngeal case. Can you guys hear me okay? Okay.
Yeah, I can hear you.
Okay, great. So I had to just give one little slide of our crew that we have here now that we're so excited to be able to have such fabulous partners. So I thought we were the second case, but our first case is an 84-year-old gentleman who has a history of a T3N1 M0 left true vocal cord squamous cell carcinoma. He finished chemoradiation therapy treated with cetuximab, and on his post-PET, there was concern for persistent disease. He had an FDG-avid lesion remaining within the larynx. He was a former smoker. He wasn't actively smoking. He had no past extremity surgeries, and on laryngoscopy in the office, he had a persistent left vocal cord mass with a normal Allen's test bilaterally, and he was PEG dependent.
Yeah, ask you, Nicole, and I'll ask the panel. Let's actually start by asking Matt. Matt, what's your routine at Ohio State? Do you guys, for these cases, do you do a DL before you recommend for or against surgery?
You mean in terms of salvage surgery or pre-op or pre?
If the patient, patient comes to you after chemo RT, you look at the PET, you look at the flexible in the office, and it looks pretty bad. I mean, you kind of know where it's going, but what's your routine? What would you do routinely for these folks?
Typically, we would biopsy them. Understanding that sometimes chondroradial necrosis, particularly if they were smoking, can look exactly the same as tumor. And I tell the patients, especially the ones that are smoking through it, it could look like tumor, but it could be just their larynx, melting away. So I typically biopsy them rather than booking a huge day in advance.
Except for DL, or you just biopsy them in the office?
By DL.
Yeah. All right. Let's see, Chad. Agree?
Yep, for sure. For those reasons, absolutely.
And also, there is nowadays it doesn't happen often, but you always want to get a sense of how much your peripheral sinuses are involved, so on and so forth. Anybody else have any comments? So that part is relatively straightforward,
Yeah, I think Bobak, I think you bring up a good point about office biopsies. I know our laryngologists can do quite a bit, including doing bronchoscopy to assess subglottic extension. But I think there's some limitations with the quality of the biopsies in the salvage setting that they can get with those small cups that they do with their operative scopes in the office. But I agree with the panel. I generally like to get them under anesthesia and get a feel for it myself.
I agree more. It's just that the view that you get, especially with the angle of the scope, is very different, and you just get a sense of what you're dealing with. Okay, let's proceed.
Okay, so this is the imaging. I just took one screenshot, but essentially you see a persistent, you can see that it's heterogeneous here. There's a necrotic area within the left true vocal cord larynx. And then, so our reconstructive options. So, essentially we were recommending that the patient undergo a total laryngectomy. I just wanted to put up for all the fellows, in terms of when you're doing a total laryngectomy, is it going to be, are you planning for a partial pharyngectomy? What are your options? So even post radiation, you consider closing primarily with suture or stapler. I personally have never done a stapler, but and if you do that, a muscle onlay with pec muscle, or you can do free tissue like serratus or a lat. And then you can also go ahead.
Let's open for a discussion. So first, tell us what's your philosophy at Case Western for these classic cases.
So I think it really depends on how much pharyngeal mucosa you have left. And that's kind of how I make my decision. So in general, I won't close primarily on a post-radiated patient, especially someone who's been radiated within 3 months, unless they have more than 5 centimeters of pharyngeal mucosa, is my rule.
Transverse closure or the vertical closure?
I usually do a vertical closure.
Ask others. Matt, what would you guys recommend at Ohio State?
For chemoradiation failure, generally we'll do an interposition, some sort of a graft, even if there is adequate tissue to close it. It seems like after chemoradiation, you're always limited unless it's those very anterior tumors in the anterior commissure that you can get away with closing it and then doing an onlay of either pec muscle or a free flap. But generally, for this patient, we would probably interpose something.
Let's see. Mike Moore, Indiana.
Yeah, I mean, I think I'm a big fan of reconstructing it with vascularized tissue for sure. Usually do a patch, just because I feel like augmenting the pharynx. If you do get a fistula, it gives you a larger starting circumference so that if it does scar down some, it's better. I love the pec flap if a person functionally is not going to, a lot of it depends on body habitus and their functional status. It's a very reliable method. It works well, but the vast majority of the time we use the thigh flap. Yeah, that's, if they're thin, thigh flap gives you muscle and pliable tissue, a good combination, and it's fairly low morbidity. So that's probably our preferred method.
Dr. Weed, what's the philosophy in Florida?
Again, you could be tempted to close primarily, and every time you are tempted, you will almost certainly regret it later. So, if there's thin and cachectic, a pec flap is a pretty darn good option, but I actually prefer forearm for these, and I would inset into the pharynx. I just think if you're taking non-radiated, well-vascularized, free tissue that you're approximating to radiated mucosa, that's better than primary closure and an onlay graft. I know that there are a lot that do it the other way, but I like to get vascularized tissue into the closure, and you augment your lumen size at the same time.
One last comment, Chad.
I think the one subset that I'm a little bit more open to primary closure is the narrow field radiation. Obviously, it's not this case, but if their piriforms are preserved and, like Matt said, they've got a, glottic recurrence and you're, just from a functional standpoint, they need a total laryngectomy. I think in those patients, they can still do well. I do typically at least overlay, and like Mike Moore said, the ALT is nice too, because you can really wrap that fascia around there and pexy it to the pharynx and or the constrictors to kind of reinforce the suture line. And certainly in these chemorads patients, Pierre Lavertu made me a proponent of the salivary bypass tube, and I've started for many years now, use those. And not that you still don't fistulize, but I think the amount of fistula and the severity is a lot less in those patients. So those are just a few of the points that I wanted to make.
So as you can see, there are different schools of thought, but everybody agrees that a chemoradiated, especially not just radiated, chemoradiated patient is really important to have some sort of vascularized tissue. And that the rest of it is really art of looking at the patient, looking at your environment and see what is better, a free flap or a pec, and there's no shame in it. I routinely do ALT for a lot of patients. At VA, I've been starting doing a lot of primary closure and then onlay, muscle only pec flap. I'll tell you, it works really well, except that every time I look at their neck, I hate, why did I do this? And I want to go back to free flap because it just gives you a much better contour to your neck when you do a free flap. But again, you have to see where you want to do. Okay, let's move on. Nicole?
Okay, so always include a pec flap. I just wanted to put that out there when you prep. So make sure that whenever you're prepping, you always include that option. So here's just an intra-op picture. This was not the same patient, I don't believe, but this is just as we're mobilizing the larynx. And then, you know, always consider what your resective surgeon is going to give you. So here's a case where they showed up with a total glossectomy, total laryngectomy, partial pharyngectomy. So that would obviously change your reconstruction. But here's where we keep going. So, and this is a total laryngectomy, total pharyngectomy defect. So first I wanted to just start out with, you know, when you've got your pharyngeal mucosa, I'd recommend at least 5 centimeters of pharyngeal mucosa to close primarily. And the smallest salivary bypass tube that you want to close over would be an 8. That's the smallest that we have and that I've ever used. So you always, in my opinion, want to start the inset with a vertical or interrupted sutures at the cricopharyngeus or that esophageal inlet. That's where the tightest, highest pressure is going to be. So I recommend that you set those sutures first. And that's where you don't want to do a horizontal mattress, because when you've got the circumferential tissue, you don't want to be constricting that down. So that's why either an interrupted or a vertical mattress is better in that location. What I recommend that from there is that you close on the ipsilateral side of your vessels. So wherever your vessels are going to be, do that closure. You can see how nice and wide open everything is. This is where you can transition to a horizontal mattress suture. You're looking at all of that closure, and you just make sure every single one of these stitches is perfect as you're getting them down. That's the side that your pedicle will be on. You stop when you get to the base of tongue on the ipsilateral side of your vessels. And this is where, if you're going to de-ep, the next step is to de-ep any of the radial forearm skin. And I show you kind of how I do it and how Rod does it. But if you take a larger area of skin, you can then de-ep and have the portion for the skin paddle. And this is also when you would want to place your salivary bypass tube. So from there, so the 2 different ways to raise your radial forearm. So Rod kind of shows the picture where he takes a larger skin paddle and then will de-ep a portion. So he'll have his external skin, the de-ep portion, and then the portion for the pharynx. I like to take my radial forearm with the picture on the right, where I have the portion, the patch that's going to go within the pharynx, and then an area of tissue that I don't take, and then the skin paddle for the stoma separate. Okay. So then from there, if you do an ALT, which I also think is a great option for these, the nice thing about an ALT is you can raise it early. So I have been burned where I started a radial forearm and then the margins came back positive, and you keep going, and you know, now you've already started to raise your forearm. So an ALT you can raise early. You don't have to wait for margins because you can adjust it, and you would just de-ep a portion. Again, a lot of skin. So you can do your stoma and your pharyngeal closure, and you've got a lot of skin for all of that. So I do like the ALT for these. When you bring it back in, so just our next step for step number 5 is now we're going to go on the same side as the, now we're going to go on the opposite side of our vessels. And so we're going to start again at the distal esophageal area, and we're going to work our way up towards the base of tongue. And now we're going to finish the closure along the base of tongue, starting again where your pedicle is, ending the very last stitch that you put in is contralateral to your pedicle at the base of tongue, and that's where your lowest pressures are going to be. So if you fistulize on that side, it's away from the pedicle and it's away from everything else. Place your medial drains for fistulas, and then any lateral drains for the neck dissection.
Hey, Nicole?
Yeah?
I'm just curious. I thought I saw maybe an implantable Doppler.
You did.
And then the other question would be, and Babak, sorry, I'm curious for you too. Do you guys ever just do buried flaps, rely on an implantable Doppler, and not use a skin paddle?
That's actually my exact question.
It's your exact question. So we do, I mean, I love the skin paddle. When I was in residency, I worked with Dan Allum at the Cleveland Clinic, and he always buried his radial forearms or ALTs. We'd have nothing to monitor. We'd actually scope patients and be trying to visualize it. It was impossible. So I think the implantable Doppler has gone a long way in terms of being able to tell you how your flap is doing, but I still love to have some sort of skin paddle. What I've learned from partners like Chad and Rod is that you can actually make a hole anywhere. I mean, even if you make a tiny little hole in the neck, if you don't have enough skin to bring it up to where the stoma is, you can make a little opening and just pull out a little bit of muscle that you can monitor. So I like to have something to look at, but I have gone to using an implantable Doppler, and I love that technology.
Yeah, I think if I could.
Go ahead.
No, I'm sorry. Just to add to that is that, the implantable Doppler for years, I tried on the vein and was totally disheartened by it. So we've gone to the artery, as many places have, and then that visual inspection of something, whether it's a muscle component or whether it's that suprastomal skin paddle, I think helps you from the venous side. So we kind of have the best of all worlds.
Well, I'm Toronto trained, so we never do the skin paddle or the skin monitor, and we always buried everything. But that was Ralph and Doug. Those guys never have any failed flap. I just saw Doug join. By the way, that was an excellent description of a step-by-step of how to do a pharyngeal reconstruction, because all these teeny-weeny things that you think about it, and then you're like in the middle of, why did I do the suture on this side versus the other side? So for all the folks, I definitely enjoyed listening to you, Nicole, and please, for the rest of the audience, don't underestimate all those pearls that she just gave you. I just saw Doug join us. Doug, would you like to make a comment? I know you always like to come up with some innovations that I have never thought about.
Okay, sorry about that. No, I thought that was an excellent description. Yeah, I think it was an excellent description. The one thing that I've done, this is all hocus pocus, but I think that, and I came to the call late because I got asked to do an ultrasound in clinic. And anyway, bottom line is that a lot of the other stuff is really important, like making sure the TSH is working, make sure your drains are working, make sure you have a drain in a place where you could get a fistula in case you do, that it drains easily and doesn't fill up your neck. All those little small things about management, I think really, really help and really help outcomes. And then if you really hearken back to some of the stuff that Eben Rosenthal wrote about with not doing neck dissections, I still do them, but it's an option to consider. And then the further research that was published on at Michigan, where really the paratracheal nodes are the important spot. So then maybe you can decrease your neck dissection and not expose your great vessels so much. And then of course, but if you do your paratracheals, you're gonna have more trouble with your trachea, but at least your great vessels are more protected. So there's a lot of small things in around this that I think have really helped improve our overall management of these laryngectomy, partial pharyngectomy patients.
So in the interest of time, I'm just going to ask kind of rapid fire 3-4 questions that always come up everybody's mind. And number one, everybody does JP or self-suction. Does anybody do non-suctioning drain, like a Penrose? Let's see, Chad.
Sorry, I do suction drains.
Okay, and Nicole, looks like you guys do suction drain. Anybody does a non-suction Penrose drain? Because in New York, a lot of people still not do non-suction drain. All right, number question. Do you guys do TEP right away or you wait, Nicole?
Wait. I have done them primarily, but no, in general, we wait.
We in Toronto used to do them the same time. Doug, would you like to make a comment? Would you wait or you do it at the same time?
I think there's a diversity of experience in Toronto. So some people put them in primarily and some people wait. I think with the advent of high quality insufflating esophagoscopes in the clinic, particularly if you're doing paratracheal node dissections, the viability of the trachea, unfortunately, is unpredictable. So I find that putting them in later, if you have a good insufflating esophagoscope and your speech and language pathologist there to choose where it goes, and for you to maybe even put in a button, even though you're not going to use a button immediately, but know where it would be positioned relative to a button and how the patient's stoma looks, is helpful. And so I like that prediction level.
What do you guys do in Ohio State?
We used to put them in primarily, but I think that for the reasons already stated by Doug and others, we have gravitated away from putting them in. And we do insufflation testing to see how their voices will be. So yeah, we wait.
I tell you, this TEP is like the smallest part of the operation. It's the devil itself because it's the one that always gives you the most distress, and it's unpredictable, and it always comes down. Okay, great. Nicole, when you finish, because you got to move on to next case.
Yep. So and then close the stoma. Talked about just salivary bypass tube. If you're doing a total pharyngectomy, you can suture, like let's say you're doing a radial-form, put the salivary bypass tube in and suture over it while it's still perfusing. Same thing with an ALT, and then bring it up to the head. You know, I avoid radial forms with severe malnutrition. I'll either do a pack or I'll do something else because they just don't heal well.
Okay, excellent. Thank you. Rusha, would you like me to put your presentation on, or you have it on now?
I think I figured it out. So
Try.
This is switching over. A question was brought up about salivary bypass tubes. Do you guys use them for all salvage repairs or just circumferential? It looks like some for both, but I just bring it up to the group.
Sure. I just do for circumferential, but seems
That's
like
the same for me.
Matt, what do you got, you guys?
I like it.
Circumferential, generally circumferential, but not the others.
I do in the salvage setting. I tend to put them in.
I occasionally put them in for circumferential.
Rod, do you guys do more than?
Yeah, I love salivary bypass tubes. I figured the only downside that's ever been brought to my attention is if you try to oversize them, and then perhaps could you be putting some tension on your suture line, and if you have a trach in or something, are you going to sandwich that between, even if it's a soft salivary bypass tube? So that's a consideration, but I tend to use them in all pharyngectomy recon.
Let's move on. Our next presenter is Dr. Rusha Patel from West Virginia. We're talking about oral cavity recon. Rusha?
sure. So let me know if you guys can't hear me. I did a little bit of a technical switch here. So I'm going to go over our first case. This is TF. He's a 62-year-old male, typical West Virginian. He is a heavy smoker, heavy drinker. He waited about 3 months to come to us. No big medical history to note. And I have a picture of his tumor. It's basically anterior floor mouth, anterior tongue. We did a clinical Allen's test, which is what we do here for the most part of the left arm that had adequate collateral circulation. And,
let's ask the panel before we go forward. I mean, it's obviously cancer, I think. I believe your picture. So how do you approach the patient comes into you, obviously, and especially as a recon person? Let's ask Rod, when you see a big, gigantic tongue tumor, can you go back to the picture, Rusha, or if you have another picture?
Yep, let me try to go back right there.
Like, what do you look for? How do you measure it? How do you approach it?
You know, well, some of it depends also on the patient and if it's real painful. So sometimes I can, so just speaking to you're saying, is it extending into the tongue or is it attached to the mandible, the inner cortex, things like this? You know, I would be looking at, it looks as though that left side that it's actually into the tongue there as well. And anteriorly behind that dentition, is it attached to the gingiva or to the mandible? So you're thinking here, how much of the tongue resected, and is it a marginal mandibulectomy if a mandible at all, or are you just going to take out or do you need to take out a segmental? And it can be difficult in the office to get that kind of exam. So sometimes I'll saturate a cotton ball with lidocaine, and that can help a little bit with the office exam. But if there's a question of whether this is bone and soft tissue or soft tissue only, then you spoke about a DL earlier. There are some patients where you'll do a DL or an exam under anesthesia just to be able to assess what type of resection you need.
Okay, let's see. Chad, what's your trick to kind of figure out the patient recon?
No, I think having a low threshold to take them to the OR if they're too painful to really examine, because the last thing you want to do is get to the OR, have to do a composite, not have a CTA. Not that you can't audible, but you always feel like a bit of a schmuck if you have to do that and didn't know ahead of time. So that I think is a good point. I really think the scans are important too, because if you get an impression on where this disease is in relation to the lingual arteries on both sides, it was into the root of the tongue. What's the concern for possible total glossectomy? And not that this was huge, but on the limited image, I at least would want to confirm that I can say vasculature and at least a unilateral hypoglossal nerve, because a forearm versus a fibula versus a DIEP or large ALT for a total gloss defect. Those are different
MRI
strategies.
Anybody rely on MRI nowadays? Both for bone, actually, because MRI is very good for bone invasion. Not the cortical part, but the change in the marrow signal, and also the extent of the tumor. Let's see, Matt, do you guys do any MRI for oral cavity?
Yeah, I mean, I think the MRI, I like it for the tongue invasion to see how deep it goes into the tongue and the root of the tongue. I think that in terms of the mandible, these are tricky defects. You know, I definitely push the envelope early on in my career on marginals for these, even when you don't see cortex invasion. But when they're smack up against the lingual surface for a good portion of it, I think controlling that periosteal margin is hard, particularly if they have a thin mandible without a composite. And so I've had a lower threshold to take the bone no matter what the scan shows, but I do rely on MRI. I do like it, and I agree with you on the bone aspect of it.
Doug?
I think the MRIs, you know, I kind of hate, got to do, a CT of the chest, CT of the head and neck, and then I'm ordering an MRI now. But I think it's really good for looking at soft tissue in the tongue. I think you're right on about the marrow space. The caveat is if they've had prior radiation, sometimes that marrow space doesn't look so good, so it's not as good a discriminator. But yeah, I find MRI helpful, particularly when you're trying to say, is this going to be, kind of a kind of an anterior glossectomy, or am I going to something near total or total? Because the consent process is totally different. One place I do back off on MRIs, if I do see a lot of metal in the mouth and stuff, I say, you know what, it's going to be, really degrade the image. So I'm not going to get it because this is spending money I don't need to spend.
So I'll move on. So here's imaging, which, as you guys were talking about, I found extremely helpful in these cases. Usually a PET scan or something similar basically shows no mandible involvement, no mandible erosion, bilateral adenopathy. And so at this point, we kind of went over a couple of reconstruction plans that I think we already touched on a little bit, whether you're talking about a forearm or something a little bit bulkier. So I'll just go ahead to the surgical management. So the patient had a glossectomy, bilateral neck dissections, and initially it was basically an anterior glossectomy, able to clear margins, kept the mandible, kept the bone, and drilled down some of the cortex. So I guess my question to the group or to whoever else is on the call is, at this point, what would be your reconstructive option?
Nicole. Nicole is classic. Friday afternoon, your partner's call, you say, hi, I'm leaving town.
Of course. Yes, classic. So, I think the base of tongue is huge in terms of overall swallowing function. By preserving the base of tongue, that's phenomenal. And it allows you to have many more options in terms of the reconstruction, because there are ways that you can really tent up that tissue, even if you do a radial form. I still like an ALT. I mean, I still like, because I'll take the tensor fascia and I'll attach it to the bottom part of the periosteum on the bone, and I just feel like it gives that level so that you don't see the tissue sinking down as much. So ALT is kind of my favorite, but I do think you have more options by preserving that base of tongue.
And this is a little bit big, but I tell all the fellows that there is a classic paper by Dr. Chapea about how to do a hemiglossectomy with a square radial forearm that I have read at least 5 times, and it's really an enjoyable read, and I highly recommend it because it changes the way you think about tongue and the movement and the height. So, but this is a little bit bigger. So let's ask Mike. Mike, what would you do for the purely anterior tongue?
Yeah, I think a lot of it depends on body habitus. If they're thin, I love a thigh flap. I think you can kind of pooch it up and give some anterior bulk that they can push against their palate. If this is one that we did go in and really didn't know about the bone, I always talk to them about a parascapular system, because you can get more bulk than a forearm and have the bone there in a pinch if you really, you get in there and actually there is involvement. Say you didn't have your CTA, I still think you could accomplish the goal with the parascapular system or subscapular system. Forearms are good if they're larger, or if you do really have bilateral innervated tongue base that can give some good mobility. It's just a lot of it just depends on bulk, and that's kind of a judgment call at the time.
Sure. So to spoil the story, your frozen sections come back, and now you're looking at this.
This is definitely Friday the 13th.
Yeah, this is a Friday case for sure. So your reconstructive surgeon's like, I don't like squamous cell anxiety being everywhere. I'm just going to take everything I have. You're staring at the poor man's epiglottis and vallecula, and you have to hook it up to his tongue. So how would this change your reconstruction plan? I think most of us would agree that we'd be going for something with a little bit more bulk. Nicole, I like what you said about the fascia hammock. I thought I was the only one goofy enough to do that, but I've loved that. And I was wondering what people's thoughts were about reinnervation as well as laryngeal suspension or some other kind of process to get the larynx out of the way and keep the phloem mouth up.
Doing that this time, I probably will call a friend. That's the time that, you know, call a colleague first when you see that. Let's call some Matt. Let's start with you. What would you recommend?
I mean, I think the key here is you need bulk over that larynx. And you really need bulk to protect, you know, if you're going to go for swallowing. And I tell patients it's about a 50-50 chance they're going to swallow with this defect. But that being said, I like a lot of fat, some sort of tissue free flap that has a lot of fat, and it can have muscle, but that muscle is going to atrophy. I tend not to reinnervate it. So for this patient, depends on their habitus. I think ALT is a great choice. You can get a large volume, you can tent it up, you can do the fascial techniques that Nicole talked about. But you know, sometimes we don't have that option. They don't have any fat there. So you could even consider a rectus, latissimus, subscapular system, or something of that sort. So it just depends on where I'd like to find the best bulk.
Doug, giving it a thumbs up. Would you like to make a comment?
Yeah, well, I don't know. I mean, I'm telling you, everybody is very knowledgeable on this panel. I'm so impressed. I can't even tell you. So yeah, I mean, I would do a rectus flap on a perforator. And you know, the perforators are really robust. I at one time harvested as you would for breast reconstruction, doing trams. I've stopped doing that. I really just go to a periumbilical perforator because life is simpler. And if you follow the breast literature, and there may be some, not sure if there's some fellows on that maybe train in Anderson who do multi-site reconstruction, not just head and neck, but they are now getting CTAs and things to look for the superficial system. So the reliability isn't quite there, and that's partly why I went away from it. So you just pick up a big periumbilical perforator, you keep all the muscle, you keep all the fascia, essentially dissect it out like a perforator lat or a perforator ALT. It feels the same. Perforator's way bigger. Usually I try to keep a couple. And yeah, Matt's just absolutely right on. You need an enormous piece of fat. And as the only thing I would say that, you know, I'm not sure that I'm right about this, is that you really need so much, like I say to the fellows, you want to put in so much tissue, you want to quit your job. If you don't want to quit your job while you're putting in the fat and say, why am I so fucking stupid? Oh, I shouldn't have said that on, but anyway, why am I so stupid to be doing this when all my buddies are drinking in the bar, making more money than I am, and I'm shoving in this stupid piece of fat. I'm 50 years old and all my banker friends are already retired, you know, then it's not big enough. So yeah, get a big piece of fat in there, like Matt said, and also suspend it. So I get Gore-Tex sutures. Sometimes I put a small drill hole through the inferior aspect of the mandible. I put it right around the hide and I pull it up. You need bigger Gore-Tex sutures. I don't have them in Canada, but if you're in the States, you can get them. They're like 2.0, be fine, 2.0 sutures. And I have had troubles with them. Sometimes you'll find this funny little, later, I just warn you, it's not a recurrence. So you can almost get this funny linear granuloma in the neck, and sometimes they spit out, but they hold it up initially.
A moment of the night. That's the highlight for tomorrow. Get as much fat as possible. And why am I doing this? Okay, go ahead.
Rush, I just had a question. When you put down reinnervation, are you talking for motion, or are you talking for those situations where you don't have a lot of fat, but you have muscle bulk to reinnervate with the 12th nerve, just to potentially, conceptually try to maintain some muscle bulk? Is that what that
is? I was thinking about muscle tone, because I think, as we all know, bulk is really the crux of this whole problem with getting these patients functional again.
Just in the first like 6, 8, 10 years of my career, I used, before ALT became the thing, as rectus, and then lat, and then I would innervate the lat, and invariably with the hammocks and such, there was loss of tone. So I've had variable results with the reinnervation, but I certainly have done it to the muscle. And then those ALTs where you take the vastus, but maybe there's just only thin muscle that you can't fold on itself. I've tried to reinnervate, but I don't know if that's just giving the fellow experience with neurophy or whether it's actually, it's a hard thing, I think, to monitor or to see whether it works, but it's certainly something I've done.
Sure.
I've gone to ALT for the same reason that you said, because the ALT is, the one thing about it is very, very, you know what you get. It's not going to shrink. And as you said, you can get a lot of fat, but still with the rectus, the muscle always makes me worried, because you're almost guaranteed that this patient is going to get radiation. There's no question with this T4 gigantic tumor with bilateral. So, and that's going to shrink your flap a little bit. All right, so Rusha?
Hey, Bobak,
Yeah,
one
go
quick
ahead.
point that I would add for the fellows. First of all, if I know this is going to be my defect, I actually love a lat. And you can design a lat to pooch up in the mouth and look exactly like a tongue. And I encourage everybody to search Mark Erkin's article on this for latissimus for total glossectomy recon. It'll describe precisely how to design the skin paddle and the triangles to deepithelialize to get it to stand up. It's an excellent article, and it's a very useful thing to have in your back pocket. I like everybody else, do a lot of ALTs for this now when you have to do this defect, but a lat works great.
Yeah, Don, I did my fellowship with Erkin, and that article was something I ingrained in my brain during that year, and that's what I did for the first 5 years. But I've transitioned over, like everyone else on the panel says, to ALT in the majority of situations.
Okay, Rusha?
So we did do an ALT. I didn't resuspend him. And post-op day 1, he looked great. Post-op day 6, his flaps started to shrink. He unfortunately failed his swallow study. He ended up getting a G-tube. And like we talked about, he did get his radiation. So this is 4 months post-op. And you just saw one post-op day 1 to this. And he saw my partner. He can't eat or drink, very poor articulation. And this is certainly a complex problem. But I wanted to post this case because coming out of fellowship, I felt like this was the most frustrating issue for me, is how you can deal with these total glossectomy defects for oral cavity and maintain their function throughout the course of their treatment, not just initially afterwards. And so I wanted to kind of discuss what the next steps would be, or what people would do to try to get this patient rehabilitated.
Great and really challenging, and I've had exactly a patient like that. But unfortunately, we're running out of time. I'm just going to ask 2 people to comment, Rod and then Doug. Just have you gone back and done more?
No, I haven't necessarily gone back unless there's been like a dehiscence. And so, Rusha, we've all seen these, and this could be from my computer here. So if there's been exposed mandible or somewhere I've had an opportunity clinically to go back and redo it, I've done that. But more commonly, we have a prosthodontist that we work with that if the tongue can't reach the palate, then you can bring the palate down to the tongue and improve some articulation. And they've even created some augmentation prosthetics that has helped reduce some of that space and improve some function, either speaking and or swallowing.
And so I don't have much to add to that. There's no question of a cancer recurrence here, right?
No.
Okay, so basically, I never do anything inside a year because I just, and preferably 2 years, and I just put another perforator rectus on top, try to build up the mound. I completely agree with Rod that the palatal drop prosthesis is worth trying in a patient. The problem, as we all know, is that, their sensate mucosa is the mucosa overlying the maxilla and their buccal, obviously their buccal mucosa. And so when you cover that maxillary mucosa, they really lose things. So although it's supposed to help with articulation, I've only found it really to help a lot if the patient's mound is actually pretty big and you're just trying to finesse some consonants, but losing that sensation is usually the deal breaker. And so if they're high functioning and they work or something, I'll go in and rebuild that mound. And I have done it, and it is problematic. I don't take out the whole flap. I just get some Gorney scissors in there. I deepithelialize them, and then I drop the new paddle on top. You have to parachute the back and then suture around at the front like you would.
Thank you. This was an excellent case and really showed the challenges of
Yeah,
total
absolutely.
glossectomy recon. All right, so I think we have Nolan, Dr. Syme, presenting next.
Yeah, thank you. Let me share my screen.
I'm from The Ohio State and
Right.
with Dr. Matthew O. Floor is yours.
Thank you. Let me see speaker view. It's not even, there we go.
46 people on the call. This is great.
All right, that's showing up. Everybody see that?
Yeah.
Thumbs up. Excellent.
Yeah, it looks good.
Yeah, thank you very much. I appreciate Dr. Old giving me the opportunity to participate in the tumor board today. So my topic was skull base and large cutaneous defects. So this is a patient VR, 84-year-old female with a scalp lesion for greater than a year. Bleeds, smells. I think we all kind of know this story. She actually presented to me after she went to the ED after a fall and had tumor trauma, and now it was bleeding. And so she's relatively healthy though. So she's only on a couple antihypertensive and a statin, never smoker, never drinker. And it measures 8 by 9 centimeters right in the vertex of the scalp. No palpable adenopathy on exam. This is her head CT in the coronal plane here. And this is a PET scan that was obtained at the outside hospital. I wouldn't normally get a PET scan in this scenario. I usually just get a CT head, neck, and chest, but PET scan was obtained, and some things light up in the left parotid and the left level kind of 2 neck EJ node area. And so the clinical staging is T4, N0 or 1, and at this point, kind of treatment options.
Question for you, Nolan.
Mm-hmm.
This is an open wound, so you could have some just inflammation in the node. When you see those nodes light up in PET, considering that the risk of that melanoma is not very high, do you confirm with FNA?
Yeah, if there was, I think that's a very, very good point, and that's what I discussed with her, that the likelihood of the cause of the adenopathy was. If there was something that that was FNA-able, I think that's a great idea. In this case, I did not.
Because most of these, even when they are gigantic, they don't metastasize. That's rare, but it does happen, and all of us have seen it. Rod, what's your practice? Do you confirm with FNA before you do elective or semi-therapeutic next dissection or parotid?
Yeah, in those situations, I would expect something on the vertex scalp like this. Would I expect it to go to level 2, or if it's going to change management somehow, then I think I have. If there's maybe not just the PET, but if there's a CT scan that shows, maybe it's rounded, maybe it's solid, maybe it's got a little necrotic center, I would. But like you said, you wouldn't want to miss this. Now that the question's been raised, you have to act on it. And I think your hand is forced a little bit here, or at least to consider it.
Non-reconstitution. Jeff, I see you've been very quiet. What's your routine? Do you take him out, or are you FNA?
I usually, if the PET scan is suspicious, then I usually favor just addressing the lymph node basin appropriately. But there's uncertainty, and the PET is like equivocal. I think an FNA is really important because it really does change the extent of surgery, and I think it's really important for patients to know what they're getting when they go to the operation. Besides, obviously the scalp lesion. So, and I think it's also important for prognosis that if there's documented regional disease, it really changes your prognosis for the entire cancer, and that's a really another important consideration for discussion.
Mike, one last word. You're the cutaneous man. What would you do? Do you FNA, or you just do it?
I'd hardly call myself the cutaneous man, but I would say if I wasn't going to be right there to sample it myself at the time, I would do an FNA, because who knows where the heck this thing's going to drain. It could literally drain about anywhere. And so I think you're not going to be overly aggressive with lymphadenectomy unless there's something that's positive disease. It'll also impact obviously the adjuvant therapy dose and extent of it. And so I think it's reasonable to know, especially if it ends up being contralateral, if this is just off to the midline, it's the other side, where you'd like to stay out of that side completely if at all possible.
And continue.
Can I just say one thing? It's atypical to have lymph node drain in this area from a scalp. So I'd be, you know, we'd look for a second primary, but I also think about something hematogenous like CLL or something. You don't, you know, because skin cancer in Caucasians goes hand in hand with some of these relatively common hematogenous malignancies. And so I'd be a little careful about not knowing what those nodes were prior to surgery, just as a thought.
Excellent. Okay.
You got muted, Nolan.
Still muted.
Sorry about that. Okay, got it. So what was going through, you know, kind of my planning with this patient was, number one, I was obviously planning a free flap. It was going to lay right in the parotid basin. So you're going to be there anyways. And then number two was talking with the radiation oncologist, knowing this patient was going to need radiation and what they were going to do with the positive lymph nodes. They really encouraged knowing the options as far as that goes. So anyways, you know, as far as the scalp recons, obviously this is on the vertex of the scalp, and based on the CT scan, there's bony invasion that's sitting right over the sagittal sinus. So your hand is forced a little bit with this case as far as your reconstructive options, neurosurgery is involved, et cetera. You know, there's local flaps, skin grafts if you have bone or periosteum available. This is, you know, the trap island flap for more posterior neck or scalp. That's not going to work in this scenario, obviously. So it's a pretty short reconstructive ladder, I think, for this defect. A couple things about this patient. She's in her 80s. She doesn't ambulate except for kind of in her living room. She travels via wheelchair. She's short, and her donor sites are with a lot of fat. Be great for a total gloss, not great for a cutaneous scalp. So vessel options are something that comes into play, and then, you know, being mentally prepared for vein grafts when you're trying to stretch to the neck in this scenario. This is a picture of a CT of the neck, and okay. In my, you know, brief experience, when there's a good flow of the superficial temporal artery and vein on a CT neck, it seems to present itself that way in the operating room as well. So
excellent case, and let's go ask around. So you brought two important points. Number one, choice of flap, and number two, choice of vessel, because where scalp is actually is very different. So let's ask Rod, how do you approach these in terms of choice of flap and also choice of vessel?
So I think we touched on this a little bit. So we just actually did this on Monday with Ted Technos and myself, and so you know, I like lat for the larger scalp defects, because ultimately, even though it may be bulky and thick, lat with a skin graft rather than lat with its own native skin. Ultimately, I think it gives you the best thickness and contour and scalp buck reconstruction. I've done ALT, we've done ALT fat fascial with skin grafts, we've done quite a bit, but if the superficial temporal, it's usually the artery, for me, is not the limiting factor, it's the size and quality of the vein and the mismatch. And so the concept of the vein graft, you know, mentally preparing ahead of time makes you accept it a bit better at the time of surgery. And also from the prep standpoint, you don't want to have a limited prep. You need that upper neck kind of prep to reach down there, and also then the leg prep to ward off those evil spirits. But large defects, I like lat muscle with meshed skin graft.
Babak?
Yeah, go ahead.
I just, you know, just for the fellows, seeing that cortical erosion, some people might be tempted just to drill out the outer cortex and to try to get into the inner cortex. You know, she's older. You want to maybe just do a soft tissue flap, not get neurosurgery involved. But I certainly have seen multiple people fail when that's attempted. And I think, as Nolan astutely pointed out, you really have to plan to do a craniectomy in those cases. There's also the challenges with getting mesh in there, and I'll let somebody else solve that problem on this call. But certainly she's going to need adjuvant therapy, but you know, you do want to get neurosurgery. Also, that if the sagittal sinus is involved, that's a pretty morbid resection for an older person, and that can present challenges too. So having the ability for adjuvant therapy, if you see the sagittal sinus has disease, that may be a place where you have to leave disease just because of the morbidity of further surgical resection. So just wanted to mention those couple of points. And if other people have other thoughts, I'd be curious to hear.
Yeah, just to follow up on
Rusha, let's ask Rusha. What's that?
just to follow up on Chad's great points, I think an MRI, when you see some bone invasion on the CT scan, I would strongly advocate to get an MRI. I think I've seen multiple cases where a small amount of bone invasion, it's really like an inverted mushroom into the bone, and then you would have gotten burned in the operating room. So I strongly would advocate an MRI if you see bony invasion.
Well, you know, the neurosurgeons won't return your page if you don't have an MRI anyway, so you might as well get it. Okay, let's ask Rusha. Rusha, what's your preference for these? And how do you approach the vessel problem?
There we go. I love the lab for these. I've tried the forearm, but there's, depending on your patient, there's somewhat limited surface area that you can get. And if you're gonna do these defects, you're probably making a really big hole. And I found the lat to be really good at covering up whatever mesh, whatever med pore people feel like putting in. And plus, if you wanna reach the neck, you have a nice skinny little muscle pedicle you can use to get even to your facial vessels if you can't get to your superficial temporal. So I really like that for these. It's kind of my go-to.
The same as Rod said, that just muscle only and skin graft, or do you bring the skin pattern?
Muscle only and skin graft, especially in a patient like this. You know, I've tried to take these, they're usually older patients, and they tend to have a little bit more adipose in the back, and then you try to get the skin paddle, and it's just so thick, it's really not going onto the scalp. So it's just so much nicer and cleaner with the muscle and then a mesh skin graft on top of it.
Matt, would you add anything about the vessels?
No, I think it, just as everybody said, you know, I think the thing that I've had the hardest problems with is the vein. The artery is usually not the issue in these cases. And so I always mentally prepare for a vein graft. And I find that more palatable just to get it done rather than worry too much about it. If I start digging around in that deep parotid trying to get enough of a stump to avoid a vein graft.
All right, Nolan, continue.
Okay. So she did undergo surgery as a large scalp resection. Like you indicated, it actually was like an inverted mushroom on the cranium. And so the defect was like 8 by 8 centimeters of calvarium bone. We were able to scrape clean the dura, and then a titanium plate was placed over that defect. I did perform a superficial parotid in just like a level 2/3. I mean, really a level 2 neck dissection on that side. Of course, the nodes were negative, but that was where I needed to be for the free flap anyways. And so that was my reasoning for doing that. And so the defect was a 12 by 13 centimeter vertex of the scalp. Like most people indicated, the lap muscle only, and then a meshed skin graft over the top with a 3-to-1 mesher. We took the 4-inch or the 4-inch dermatome and then did a 3-to-1 mesher. Hooked it up to the superficial temporal and the superficial vein, superficial temporal vein. Immediately the vein was not flowing. It's pretty obvious. So we cut it, let it flow, took an EJ vein graft on that same side, and then grafted it to the facial vein. And that worked out well. And then there's some Penroses in that kind of show up here. But so this is how it kind of came about. She actually did pretty well despite her age and other comorbidities. She's in the hospital longer than most people, but this is at 3 weeks, which, you know, I saw this in clinic and I was like, well, I think that's okay. Not sure, but, you know, it did heal long-term very well and pretty happy with that. She actually went through radiation after and did fine with that as well. They gave her 60 gray to that area, and then the parotid in the neck was obviously spared in that scenario. So I kind of brought up, I know we've talked about a few of these, but I think that certainly open for more discussion for sure.
Yeah, let's ask. So one thing I have learned, and I agree, you know, I don't have anything that these patients, especially with that gigantic skin graft, are actually quite hard to take care of afterward in the hospital and in the post-op, because the skin graft always looks funny and they have a lot of crusting and it's kind of hard for them to lie in the bed and all that. Any tricks? How do you guys manage this post-op? Let's ask Chad first. What do you do for post-op for these patients, especially with the skin graft stuff?
Well, actually, I got it from Razai. There's that plastic mold you can kind of put on there and suture on. Razai, what's that stuff called?
We experiment a little bit with Aquaplast or
Aquaplast, yeah. So just basically suturing, tacking down some Xeroform, covering the whole thing with that. And then the Aquaplast actually kind of fixing them with a sort of a helmet that's sutured down there, at least to prevent them from rubbing on it. And not that it's perfect, but that seems to work reasonably well. And like you said, picking the crusting off, trying to have them keep it moist. The skull caps can work pretty well too with Xeroform after the Aquaplast comes off, and just have something to kind of hold the Xeroform gauze on there and the different moisture tinctures or ointments that you're putting on it while it's healing.
Doug, I was going to ask you a couple of questions. Any comments in this? And we didn't talk too much about lateral arm, and I know you have an affinity for that flap. So if you just tell us a little bit about what's your criteria for lateral arm, and also if you have any comments regarding the scalp defect.
I think also some people at Ohio State have published on it recently too, I think. So lateral arm, I use it for parotid defects. So because the pedicle's short, it's not super short. It's not as short as you would think, and you can harvest it more distally, but it's better for parotid. I'll occasionally use it for tongue, but I don't use it for scalp. It would be too hard. It'd be really, really difficult to pull that off. So I use it for much lower in the neck. And when I'm in the parotid, I use the occipital artery, and it makes things pretty easy because the occipital artery directly overlies the internal jugular vein, and you just have a nice little arterial recipient site there and venous recipient site. With this type of, the one thing that I do to hold the skin graft down is I just get one of those big Xeroform rollers. They have them in burn programs, and it's just like I don't know, it's a roller to Xeroform. I don't know how long it is. And I just sort of staple one end and I roll it across and I staple it, then I roll it back and I just zigzag back and forth with the Xeroform. And I get about maybe 3 or 4 layers going. And then I just take a leave-in sheets and I just staple them right on. And then I leave them there for 3 weeks. And I leave a little segment of muscle hanging out that we can test. And that's what I do. And then with this image here, the only other thing I do that's different is I wouldn't skin graft. I don't know if this is any better at all, but I don't skin graft the part where I leave the scalp open. If I have to do that, I just put bare Xeroform on that because then it'll tend to contract over the muscle. And then that skin almost comes together, and then you don't have a skin graft going down the side of the head to the ear. But I mean, you've cut off their scalp, so I mean, match is pretty good. But that's about all I have to say over and above this very excellent.
Okay, well,
outcome.
Perfect. Thank you again, Nolan. All right, so it's 8 o'clock Eastern Standard Time. The debate is coming in an hour. Thank you all for joining us in this fantastic session. I hope I definitely learned quite a bit. I would like to thank all the panelists, Dr. Patel, Dr. Rezai, Dr. Old, Dr. Chapea, Dr. Syme, Dr. Fowler, and for their excellent presentation and discussion. Also, Dr. Don Veed and Michael Moore, my partner in crime. We are going to have another session in 2 weeks. This is in Larynx on October 21st. Please join us. We would welcome any of you for our presenting cases, joining as an expert, and teach us a few tricks. Have a great night. Thank you.
Thanks, everyone.
Thanks, everybody. Great job.
Thank you. Great night. Thank you.